Hi everyone, this is live from the first affiliated hospital of Harbin Medical University. And today we are in the Trinity Hospital. So as always, I've introduced my colleagues first. The first operator is Dr. Shi Huaizhang, who's a very experienced doctor treating the carotid and vertebral artery stenosis. And the second operators are Dr. Wang Chunlei and Dr. Li Yuchen. And we have two moderators, and Dr. Wu Pei and me. My name is Li Jianqiang. So first, Dr. Wu will introduce the case.
Hello everyone. Let me introduce our cases. This is a 60 years old male and have the persistent deafness for 1 month. However, we have treated with the aggressive medical treatment, used aspirin and other drugs. However, he showed no significant improvement in symptoms. He has some risk factors, for example, the type 2 diabetes for 7 years, hypertension for 20 years, and atrial fibrillation for 1 month. And the CT results show he right vertebral artery C4 segment have the stenosis larger than 70%, and the left vertebral artery C4 segment nearly occlusion. So his laboratory data, we can see the glucose is abnormal and his BP is abnormal. Now this is the DSA result. We can see the junction between the basal artery and the right vertebral artery is very stenosis, larger than 17%. Just like here, and this is the angiography result. Also, we can see the right vertebral artery is a dominant artery. This is the lateral angiography. We also do the left vertebral artery angiography. We can see it's a dysplasia, and also the C4 segment nearly occlusion. We also do the right intracranial artery and see there's no compensation for the basal artery. The left side also have no compensation for the basal artery. We do the high resolution MRI. We can see there is a plaque at C4 segment of vertebral artery, and just like the arrow C. On the left side, nearly occlusion, great arrow C. So we can see the plaque here. And this is the occlusion. And this is the CT result, just like the DSA result. The right side is a severe stenosis, and the left side is nearly occlusion. This is the CT result. We also do the MRI and the DWI results show there's no acute ischemia stroke. So today we may use the new instrument, the Fastunnel balloon catheter. It's a very interesting catheter. First, he has a balloon. You can use balloon to pressure the lesion, and also you also can use the balloon catheter to dilate the stent, just like this one. It's a balloon catheter. First, we use the wire across the lesion and use the balloon to pressure the lesion. And after the lesion, we can use the balloon catheter to dilate a stent. We can reduce the numbers of exchange to reduce the wire puncture risk. Just like the movie, we retreat and delete the stent.
Yeah, so Dr. Shi, I think today we have very good case. It's different from last case. So 2 weeks ago, we demonstrated the treatments of carotid stenosis and vertebral stenosis. But today's case is very different. The stenosis is in the intracranial part. So what's your strategy for this patient?
Okay, as the Professor Wu showed, the patient is both the right and the left vertebral artery stenosis. For such case, we should focus on the dominant artery. In this case, the right one is the dominant artery. So we the strategy we should focus on the right one. For the right one, there is two segments, two lesions in the right vertebrator, and the first one is the close to the junction. It's very severely stenosis, and the second one is this one. So we should put two stand in this patient. We will use a new instrument, Fastunnel, the balloon caster. We can navigate the stand from the Fastunnel, the balloon caster. So it's very easy.
I see, got it.
Okay.
So I have a question about this case because you just told me the right side is dominant one, and the left side, the stenosis is very severe, almost totally occluded.
Yes.
But so you are going to leave that because it's caused by dysplasia, or it's because it's not dominant side. That's why we just leave it.
Yes, because it's not dominant. It's maybe it's a dysplasia. So we don't need to treat it. From the MRI, we can see the blood vessel, blood vessel's wall clearly, and we can see the plaque here, and we know it's atherosclerosis stenosis, so we treat it.
Yes. I see. So the use of high resolution MRI is super important.
Yes,
You can confirm the etiology of this stenosis. So right now we are sure because this is caused by atherosclerosis, not dysplasia for the right side.
Yes.
Okay, as you mentioned, you are going to use a very new device. It was invented by a Chinese company. I think the audience should be very interested in knowing how to use this device. So now you can start your work.
The first step, I will advance the wire and the microcaster across the lesion to the base lateral, and take a select angle to show the microcaster is in the true lumen of the vertebral of the base lateral.
I see. So because there's two lesions, Dr. Wu,
sure.
the distal one is very severe and the proximal is kind of severe, but not that severe. So our strategy, we will treat the distal, the most severe one first.
Yeah, sure,
and then
sure.
The
And then maybe we choose the proximal one.
I see.
Yeah, because the stenosis is very severe. So first we use the microwire and the microcatheter to across the lesion. And just like Dr. say, he need first to do a select angiography to make sure he's in the true lumen, not puncture.
So when we deliver the getware, we should deliver it as distal as possible, or?
Yeah, sure. Because you go distal, you can give me more support.
I see.
Because the microwire, the tip of the microwire, maybe 3 centimeter, is very soft, designed for very soft. So if the microwire is soft, it cannot give us enough support. We can see he's in the true lumen.
I see.
Okay.
That's very good.
Yeah.
Dr. Wu, it's kind of controversial, whether or not to treat intracranial vessel or intracranial stenosis with the interventional approach. It's kind of controversial. So far, there's no studies confirming the efficacy of this interventional management. So what's your thought on this? At least what's the indication for this patient?
Actually, there's just like you say, there's some controversy. The most famous trial is the Sunrise trial. He do a compare because the Stent and the traditional medical treatment. The result is not good for Stent, but the trial have a lot of problems. For this patient, we know he have two vertebral artery. One is dominant, another is near the occlusion at the dysplasia. But the dominant is the Stent severe. Once the dominant occlusion, the patient maybe have severe mobility or motility. So for this patient, we advise use the Stent.
I see, got it. So right now, Dr. Shi is exchanging the wire.
Yes, we changed along 300 millimeters the wire, and from this wire we will advance the Fastunnel, the balloon caster. Yeah. For the intracranial stenosis, the standing, the operation, the most dangerous, the complication is the blood rupture. It's bleeding.
Yeah.
we are very concerned about this complication. So we should use a very soft wire at first, and with the microcatheter. And after the wire's assistant, we navigate the microcatheter to the very far. And after that, we make sure take a selective with the angle, make sure the microcatheter is in the true lumen,
Yeah.
and after that we navigate 300 millimeters along the wire, and after that we pull back the microcatheter, and from the long wire we navigate the balloon.
Okay, I
Yes.
see.
And the question you asked, why we treated the intracranial stenosis, because there's no clear evidence
Yeah.
that the clinical trial, because the intracranial stenosis is the main cause of the stroke in Asia, especially in East Asia. About 50% stroke in China is because of the intracranial stenosis.
So right now we have a new device. We can decrease the number of device exchanges. I think this will definitely decrease the risk of complications. And again, patients can benefit from this new device. Once the wire is engaged, so any movement should be careful, right?
Sure,
Yes,
Just in
sure.
case
For
of
the operator, he need to focus on the tip of the micro wire.
yeah.
If the micro wire across or go maybe puncture the perforator or puncture the vessel. So we can see the marker of the Fastunnel here. You can see.
There are 3 markers, right?
Yeah, yeah. The first one maybe the catheter tip, and the second one and the third one maybe the balloon.
The balloon size.
Yeah,
Indicate
sure.
the balloon
The second
size.
and the third one between is the balloon.
Oh, I
Okay.
see. No, it's engaged already.
Yeah. So no, sir. Maybe we need to angiography to make sure the lesion.
Yes.
Okay.
Let me pull back a little.
Okay, okay. Be carefully, because sometimes angiography the pressure is very high. May focus the, all the system go high. So may puncture the vessel. So we put the balloon as a lesion. We need to make an angiography and maybe withdraw.
Okay.
So
For the intracranial standing, we should, when we inflate the balloon, we should very slowly
Angiography.
because it can decrease the it can decrease the dissection rate. Yeah. Okay.
So maybe angiography again, sir.
No. I think it's good.
Now we can see this is the stand.
From here to here.
Yeah.
Okay.
This is no tape one?
Not tip.
Yeah.
Yeah. Not tip is more safer, I think.
Yeah. The E2 stand have 2 taps. First one have the tap, have the tip. It can make the stand very when delivered, it's very stability. Another one is no tape. Because if this one have some tape, maybe puncture the basal artery.
I see.
So for this one, doctor choose the no tape one. Yeah. It's open, sir.
Yes, I know.
We do angiography first, see whether there's some vasospasm.
So before the release of the stents.
Yes.
I think it's good. It's good.
It's good. I like this. It's not like the coronary interventions. There's a lot of blood on the table.
You don't need it.
We don't care about
that.
that.
Yeah, because we are very concerned about the thrombosis in the cranial. Yeah. More. Okay. Go back.
So Dr. Wu, for the first stent, we chose the self-expandable stents. So if it's intracranial stenosis, we always use self-expandable stents, right?
Sure. Most time for the intracranial stenosis, we use the self-stand. For example, the MC and the artery and the basal artery, because in this station we have a lot of perforator artery. If we use the balloon mounting stand, we delete it. Maybe we lead to the perforator occlusion. It's very common. So for most time we use the self-expand stand here.
I see.
Yeah. tape is not soft enough.
Mhm.
Now we change another
Soft
soft
one.
one. The track size
Mhm.
software is made in Micronation company, I think.
Mhm.
Micronation, yeah.
Mhm.
The tape is more soft, easy
Mhm.
to across the
Mhm.
legend.
Mhm.
Okay, okay, we across. We can see the tip of the microcare
Mhm.
here. Okay. Select angiography. Okay. Okay.
Yes.
So what's the size of the balloon?
The first balloon is 2 by 15. The second one we will choose the 3 by 20 or 3 by
We'll
yes.
start from the small one.
Yeah.
Yeah.
Okay.
Okay.
Give me the roadmap.
Now we do angiography first because
Mhm.
we worry about if the balloon to across reach the lesion, maybe angiography vasospasm again.
Mhm. Ah, I
So,
see. Okay. What's the question? Uh-huh. Professor Shi, did
Yeah.
you get the question? What's the criteria for the use of Fastunnel
Yes.
device?
What?
The criteria, the patient selection for this new device.
Yes. 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 Because the fastener is more stiff than the wingspan and then the gateway,
Mhm.
so we only use for the straight vessel,
Mhm.
and the distal part is very clearly and
Mhm.
very straight,
Mhm.
just for
Ah,
such case.
I see. If the vessel is kind of tortuous, maybe
Yes.
Yeah, we can
Fastunnel
use
is
this
not a
one.
good
It's not
choice.
a good
Yeah.
choice. Yeah.
Ah, I see.
Oh,
We need to see the hazard.
okay.
So because the balloon is very hard,
Mhm.
so now you can see the castle have been pushed down.
Mhm.
So now when the operator feel, oh, we cannot see the tip of the hazard,
Mhm.
we need to make sure where the hazard.
Mhm.
Oh, sir, you need to focus on the tip of the
Yes.
where, okay? Oh, okay, good. Just here is okay. So now pressure is also 6, sir, okay?
Okay.
Now we can inflate the balloon.
One.
Sure.
1,
Slowly by slowly.
2.
Longer than 23. No, it's not long enough. 13, 30, okay? 30 or 37.
So we decided to stand here.
Yeah,
Okay.
sure.
Yeah.
More water.
So because we can see there's some white in the lesion,
Mhm.
so we be concerned whether this is decision, decision. So maybe
see.
Stent is more safe.
Mm-hmm. Dr. Shi, because
Yes.
right now we are kind of worried. Maybe there's
No tape,
dissection.
okay?
That's why we decided to stand here.
Yes.
But
Okay,
if there's
okay.
no,
Perfect.
no possible of dissection, we just leave it, right? Only balloon dilatation.
If this the legend is very short,
Mhm.
if after the balloon inflating, there is no dissection and stenosis is not very high,
Mhm.
I think I will leave it alone.
Uh-huh.
I will leave
Okay.
it alone.
Uh-huh.
Yeah, but if the dissection or
Mhm.
like this case, the legend is very,
Very
long,
long.
Oh,
very
I see.
long.
Yeah.
I'm worried about the long term result is
Mhm.
not good.
Mhm.
Just the balloon here.
I see. It's better to put it stand here.
Yes.
Yeah. From here to here, 30.
From
Oh,
here
okay,
to here,
37.
Because,
39. No tape.
Because I'm worried about the dissection.
Yeah, sure.
Long one should can
Because
more
maybe
safe.
here is a dissection,
Yeah,
so
more
we
long.
need to cover it.
Mhm.
Yeah,
Mhm.
more
Yeah.
long, more
Maybe
safe.
dissection from
Yeah.
here, maybe.
Yeah, we have to make sure all the dissection are
Yes.
covered.
No
with
tape,
stents.
no tape.
All the legends
Okay.
should be covered by the stand.
Yeah.
So I prefer a long stand, self-depending stand as
Yeah, right. I think. So because of the previous stent, we cannot put this stent with the tape, right? We
Yeah,
have to put this stent
yeah.
with no tape.
not tape.
Yeah, because the microcatheter
Mhm.
cannot go very distal.
Oh, I see.
So
Got it.
to to make sure no tape is more safe because tape may puncture the vessel.
Yeah, right.
And we think the stand, two stand, not cover, sir. Okay.
Thank you,
Angiography.
Andrew.
A dissection
Yeah,
here.
we can see the section here.
Yeah, so if we just leave it alone and not put the stand here,
That may cause some
maybe the
problem in the
result is
future.
not good.
Yeah.
Before we inject the terifibin, and we should take a CT view, CT scan, and make sure there's no bleeding. No bleeding.
I
Yeah.
see.
Yeah,
Yeah.
maybe more safe, sir.
Yeah,
Because
right.
when the blue dilation, maybe some perforator, maybe rupture.
Yeah,
Yes.
you're right.
Yeah.
If there's bleeding, we still give the
Yes.
antipleural
It's
therapy.
devastating.
Yeah, it could be disaster.
During the
Yeah,
operation,
that's
intracranial standing operation, we should tell us the bleeding.
Yeah.
Not bleeding. Yeah.
We have to always remind us.
Yes,
Yeah.
remind
Several
us, yeah,
hemorrhage.
yeah.
Okay, I think time is enough. Just
So,
do CT scan. Okay.
it's not an easy case, I think,
Yeah,
because
sure.
two stand and two lesion in the one arterioles. And
Yeah, right. This is a
Yes.
very complex case.
yes.
But I think with the new device, we
Yes.
decrease the number of exchanges.
Yes,
So
yes.
that should decrease the complication
Patient,
rate. Yeah.
I think, yeah.
Check it. Okay. Check it. So I think it's good, sir. No hemorrhage. Okay. That's good. So
bleeding.
injection.
Okay. All right, audience, I think today we have shown a very complex case, also very interesting. We choose a very new device. So as you can see, we did decrease the number of device exchanges. So I think these patients may benefit more from this new device and also this procedure. I think Dr. Shi Huizhang, Dr. Wu Pei, and also other doctors, nurses, technicians, they have sacrificed a lot for the success treatments of these patients. And thank you so much for watching. Hope to see you again next time.
Thank you.
Bye-bye.
See you.
Bye-bye.